Thanks, Abigail. Okay, good morning, everyone, dear speakers, dear participants from wherever you are joining us today. It's really a pleasure and an honor to welcome you on behalf of DisQo to this first of a series of 3 webinars that will explore and delve deeper into how racism and discrimination impact health and how we can tackle this issue taking a cross-sectoral approach. My name is Raymond Gemen. I'm a Senior Policy Manager for Health Equity at EPHA, the European Public Health Alliance. Last week, the main football club in Ghent, here in Belgium, removed 200 racist comments underneath a TikTok video showing dancing and celebrating kids 7 to 9 years old. And I was watching the news with my 8-year-old daughter, who's also playing football, explaining to her how cruel and horrible and hurtful this is, and thinking about the conversation that these kids must have with their parents. I cannot imagine how it must feel to be looked at differently or suspiciously, to be judged on the basis of skin color, gender, or disability, to be rejected for a job or for a rental house because my last name is not Smith, or indeed to receive a late or no diagnosis when being sick, to get a different treatment because the sensors of medical equipment are developed and trained and calibrated with data using data from people with white skins, or have a higher risk of dying because of policies and practices that treat people differently. And then, of course, the enormous impact that lifelong racism and discrimination have on people's mental health and well-being. DisQo is best explained as a network of organizations, of people across sectors who know that racism and discrimination make people sick, who know that racism and discrimination kill, and who want to take an active stance against racism and discrimination. They want to be and they want to act anti-racist or anti-discrimination. But what do these terms really mean? What is racism? What's the difference between interpersonal or institutional or structural racism? And what's the difference between health inequities and health inequalities? So the objective of today, and Abigail, you can show the first slide, is to discuss the importance of language and definitions from different perspectives. So we will hear from Rosalina Racheva from the European Fundamental Rights Agency on how definitions are crucial from a research and evidence gathering perspective. From Rado Sarieva, who works at ENAR, the European Network Against Racism, who will stress the importance of empowering and involving people who suffer from racism and discrimination in building that language and narrative. And we were supposed to hear from Michaela Moa from the European Commission DG Just, but unfortunately she had to cancel last minute. I mean, just an hour ago, she informed us that she could not attend due to personal circumstances. But as this is a webinar series, we will definitely re-invite Michaela, as she is the person behind the EU anti-racism strategy. And also we want to hear from you. So these webinars are an opportunity for us to engage with a wider public. So please, while the speakers present, do drop your questions in the chat. Please start with the name of the person who you are addressing. And again, leave them in the chat. The Q&A will be moderated by Jacqueline Bouwman-Busato from EASO, the European Association for the Study of Obesity. But to kick us off, we'll have some welcome words from Irène Athanassoudis from DG SANTE. So DG SANTE is the founder and the facilitator of these thematic networks and the associated webinars. Irène is a policy officer at DG SANTE, and she will tell us a little bit more about these thematic networks and also about the other thematic networks that are currently running. So Irène, please, over to you.
The Unit for Cancer and Health in All Policies in Directorate General for Health and Food Safety. And I welcome the establishment of this thematic network on anti-discrimination and health equity. I have to say that this initiative comes out of a call DG SANTE launched in summer 2022 for cross-sectoral approaches in reducing health inequalities. Under this same call, another two thematic networks have been established, one on managing health inequalities through artificial intelligence, and the other one on mental health in all policies. All these thematic networks are hosted by the Health Policy Platform and will deliver the joint statements by April 2023. The links among all these networks are obvious because all they say that they take the discrimination as a very seriously, as an important aspect that has to be tackled. And I hope that there will be ways of cooperation and cross-fertilization of ideas between all these networks. The DisQo network, as we call it, this one today for anti-discrimination and health equity, is the one that could make the links and bring interested parties from different sectors all together, establishing the general context of understanding and collaboration for health equity. In September 2020, the European Commission released a 5-year anti-discrimination and anti-racism action plan for the Union and acknowledged the need to tackle the underlying problems of structural racism in the Union. In addition to legislative measures, the Commission committed also to use additional means, for example, member states' national law enforcement, media, civil society, etc. As did SANTE at that time, we promised to use the health policy platform and include a specific focus on reducing inequalities based on racial and ethnic origin and other kind of discrimination, and pass on proposals from civil society to the EU and national level policymakers. The establishment of a thematic network working on health equity can help by raising awareness among the health professionals that are members of this platform, other social services, member states, and provide opportunities for cooperation with and beyond the health sector. The reduction of health inequalities, we know that requires mobilization of different and diverse services, social services, education, employment, housing, justice, and health. It's a kind of circle. Everything is connected with the other domains, and health is in the middle of all that. In addition to the EU Anti-Racism Action Plan, the Commission has put forward and implemented and is implementing a number of EU strategies for equality, for Roma people, for LGBTI people, for people with disabilities. Health and healthcare is, of course, an important sector where positive changes are needed. This is a very good momentum to take stock of all that, disseminate the messages, and organize the cooperation. The work of the DisQo network could support and mobilize membership organizations in member states as well as member states authorities and complement their intelligence and so help them to make progress in health equity. We rely on EPHA and the other partner organizations of this thematic network in developing the conditions of meaningful cooperation across the different sectors and policies all together towards commonly shared objectives and aligning the health goals with overarching priorities. More importantly, the joint statement, which is the formal final product this network will deliver by April 2023, should not be limited to a paper, a kind of wishing list for the Commission, but incentivize actions that could be taken forward by the members of the network and inspire others to act also for better health equity outcomes. As you certainly know, equity and health equity is not only a moral principle. It contributes to sustainable development goals, such as the objective for good health and well-being for all at all ages. In a Europe with decreasing demography, not wasting the potential of people is crucial. Racism, xenophobia, and discrimination are fundamental determinants of poor health, I will say, and should be taken into consideration in the design and implementation of public health policies. Thank you for your attention, and I'm looking forward to interesting contributions for this webinar.
Thank you, Irène, for providing the context from the health and the DG SANTE perspective. So we'll now move on to Rosalina Lacheva. Rosalina is head of the anti-racism and non-discrimination sector at the EU Fundamental Rights Agency. Rosalina, please go ahead.
Thank you very much. I hope you hear me. So I will kind of structure my input quickly to go first through the law and policy and how they link to the thematic area that is today the focus of that webinar. And then a bit to touch upon racism on individual and structural level and the linkage to health. And then I will speak a bit about different challenges in measuring structural racism and how these complex causal mechanisms have to be modeled. So going back to law and policy, many of you are aware, and also Irène mentioned a few points already. Article 21 of the Charter recognizes the right to be free from discrimination, including on the grounds of sex, racial or ethnic origin, and religion or belief. Article 35 guarantees the right of access to preventive health care and the right to benefit from medical treatment under the conditions established by national laws and practices. EU law protects against discrimination on grounds of sex and racial or ethnic origin when accessing health care, and I just underline that now, only on those grounds. This means this could produce, of course, a hierarchy of grounds. For example, if you look at intersections of sexual orientation with racial or ethnic origin or religious affiliation, or looking at age and disability as intersection with ethnic or racial origin, you might end up with with a gap in protection. Many countries, of course, the national legislation are going beyond that, but on the EU level, there is unfortunately still a hierarchy of grounds and protection gaps. So the EU Anti-Racism Action Plan, as mentioned by Irène already, recognizes the existing health inequalities suffered by people with a minority racial or ethnic background and sets out that it will use policy measures and funding programs to combat racism and discrimination in access to healthcare. The EU Roma Strategic Framework sets out one of its main objectives to improve Roma health and increase effective equal access to quality health care, and calls for cutting the life expectancy gap by at least half, and for ensuring that by 2030 Roma women and men live 5 years longer. Moreover, the Anti-Racism Action Plan stresses that racism is often deeply embedded in our society's history and that it can be reflected in the way societies function and how citizens interact with the state and public services. Why I'm mentioning that? Because this is an explicit mentioning of structural racism and structural inequalities and institutionalized practices that need to be tackled and looked at. So if I go to the racism on the differentiation, because we talk today about language and definitions, this is the main focus, I will go a bit into the differentiation between racism on the individual level and racism on the structural level. So healthcare system may create barriers in access to healthcare or provide healthcare of a different quality to racialized groups. Communication and language barriers, for example, may affect groups specifically protected by anti-discrimination law, and health users might experience a lack of dignity and respect when meeting, communicating, and interacting with healthcare staff. Individual persons or individuals and representatives of particular groups experience racial discrimination and racism on an individual level. For example, among all groups surveyed in FRA-CU MEDIS 2 survey, some 13% said that they experienced discrimination when using healthcare services because of the way they dress, such as wearing a headscarf or a turban. Roma women aged 50 or above in that survey reported their health status as bad or very bad almost twice as often as non-Roma women. It's a kind of 55% versus 29%. The FRA Roma survey from 2021, the most recent, shows that the share of Roma experienced discrimination when accessing healthcare increased between 2016 and 2021. In addition, one's identity encompasses, as I mentioned before, multiple intersecting characteristics that might be recognized and that must be recognized, not just racial or ethnic origin, but also sex, age, sexual orientation, and disability. So, in addition to individual acts of racism, there is a growing understanding of the systemic nature of racism rooted in historical patterns, state structures, and manifested in institutional practices. Acknowledging structural racism means moving beyond the individual level of racism to focus on the structures in place that drive and sustain the inequalities and disadvantages experienced by racialized communities. The EU Action Plan and the European Commission emphasized the need to highlight structural racism and to move towards targeted measures at member state level to address that issues. However, there are challenges in measuring structural racism and modeling complex causal relationship. And if I take, for example, one of the definitions available, like the UN Office of the High Commissioner for Human Rights, or CHR, defined systemic racism as the operation of a complex, interrelated system of laws, policies, practices, and attitudes in state institutions, the private sector, and the societal structures that combined result in a direct or indirect, intentional or unintentional, de jure or de facto discrimination, distinction, exclusion, restriction, or preference, etc. So if we look at one of these definitions, it becomes clear that it is a multidimensional, multi-level concept that refers to different dimensions and levels. You have rules and norms that are on the structural level. You have attitudes and behaviors of people working in institutions, which is on individual, but because in institutions, they are involved in structures. So you have the structural level as well. You have obstacles that are indicator of the structural level. You have outcomes that are on individual level, but may have composite outcomes that show the structural level. So these, to put in a complex relationship, you need, for these causal linkages, you need multiple complex models, and you need to control for all the different levels in order to come out on to extract the structural level. So this has an impact for analysis and for the interpretation of data on individual outcomes. That means you need multiple measures for multidimensional concepts. You need multiple questions in a questionnaire, for example, to cover all relevant dimensions or multiple indicators. And of course, the complex cause-effect interrelations between dimensions. So you need to have all the different levels represented, and before, for example, to assume an access to assess a causal relationship, you need to account to control for many relevant causal factors that might produce a particular outcome. So to evidencing or proving systemic inequalities might be complex. Still, structural racism is mirrored in socioeconomic inequality and poverty in many areas of life, and these factors amplify each other. And I will give you one example from our data. For example, while life expectancy is increasing for both Roma and non-Roma, Roma continue to have a much lower life expectancy than the general population. The estimates based on data collected in 2021 from the Roma survey suggest that Roma women live on average 11 years less than women in the general population, and Roma men 9.1 years less than men in the general population. And these are the average values, and you have, of course, variations across the countries. For example, the largest difference are found in Croatia for women the gap is 15.7 years, so almost 16 years, and in Czechia for men 13.4 years. So based on that survey. Furthermore, the COVID-19 crisis has highlighted the consequences of existing health inequality suffered by people with a minority racial or ethnic background, and revealed the extreme exposure of excluded and marginalized Roma communities to negative health and socioeconomic impacts, or other racialized communities. In addition to high risk of infection, for example, due to crowded settings, there was also a proliferation of anti-Gypsyism and hate speech by politicians, presenting Roma as a collective threat to the general populations. So I will stop here. There are a few, of course, one could discuss the different definitions. One could go also back to protected grounds, the definition of protected grounds like racial or ethnic origin. And one could, of course, discuss how that these definitions do not imply to reiterate and reproduce race and the existence of race, but you can use it as a self-identification dimension and use that self-identification dimension by applying the human rights-based principle to collect data, and of the human rights-based principle of doing no harm when you collect such information. And with respect to the general data protection regulation, you can continue to, and you can start collecting such data in order to show the disparities with regard to racial and ethnic origin and all the other intersecting protected characteristics. So thank you very much.
Thank you very much, Rosalina, for this comprehensive and, I must admit, quite complex overview of these, multi-dimensional complex analysis methods that you would need to apply to really disentangle, how all of these factors work together. So for the audience, please, if you have any questions for Rosalina, do write them in the chat. Start with Rosalina, so that will help Jacqueline later to facilitate the Q&A session. So we'll now hear from Rados Zarieva, who's a policy and advocacy advisor at ENAR, the European Anti-Racism Network. Rados, please, the floor is yours.
Thank you, Raymond. Good morning, everybody. First of all, I would like to thank the network for this invitation and the opportunity to take part in this discussion panel and address the importance of language terminology, but also the meaningful participation of racialized groups in the process of deconstructing narratives and facilitating policy and decision-making related to health equity. Let me first start with a few words about the organization that I am representing. So ENAR is a pan-European network bringing together approximately 150 members, human rights organizations, but also national and local organizations raising the voices of racialized population groups. ENAR offers a platform for civil society cooperation and policy dialogue, building bridges between communities to advance racial equality and justice through advocacy, research, and cooperation across Europe. As many other organizations tackling racism, we are often confronted with certain limitations when we are addressing different manifestations in racism, including in health. Often this is due to the lack of common definitions, comprehensive and inclusive language and terminology, which also impacts not only the outcomes we obtain through projects and actions, but also different policy efforts aiming to ensure the effective protection against any forms of racism. As it has already been highlighted by civil society organizations, but also previous speakers, language and terminology play a crucial role in building comprehensive narratives, which in return affects policy and decision making. Narratives influenced by existing biases in society, but also stereotypical perception of certain population groups, de facto reduce the effectiveness of the efforts to combat racism and discrimination in major areas of life, including health, and commit to perpetuate existing inequalities in health. And this affects also physical and mental health of individuals and communities. For a long time, health disparities have been addressed mainly from socioeconomic perspectives, leaving a very little space to the discussion about the manifestation of racism and systemic discrimination in health and how it affects different vulnerable groups. Therefore, today's debate and the topic of today's webinar, it's timely, very relevant, and very helpful to advance racial equality, also to strengthen the efforts to combat racism and mitigate its consequences in education, health, and other factors which play a crucial role in maintaining communities and individual health. As an organization raising the voices of racialized population groups, we would like to highlight not only the importance of building narratives which reflect the realities of those who are excluded, who are marginalized, who suffer racism also and different forms of discrimination, but also the need for ensuring their meaningful participation in all stages of the process of building narratives, defining language, terminology, which also influences policy and decision making. For multiple reasons, including socioeconomic barriers and disadvantages, but also existing practices of segregation in education and housing, social exclusion, racialized groups faces visible and invisible barriers when it comes to participating in the public debate, whilst their participation is decisive to achieve a real change on the ground. Therefore, it's important to strengthen our efforts to first assess those barriers, analyze them, and then propose adequate solutions to ensure the meaningful participation of racialized communities. This cannot happen without providing equal opportunities for meaningful participation. Just a few examples for such opportunities can be for example, covering travel expenses for those who live in isolated areas or those who are exposed to poverty and social exclusion and who cannot freely join the public debate, who cannot freely raise their voices and actively take part in policy and decision making. Those equal opportunities should also take into account existing intersectional inequalities based on factors such as ethnicity, race, gender, age, disability, administrative and social status. For example, it might be necessary to provide training and language support to people and communities whose first language is not the main language of the country. Another example is that most of the time we have public consultations, we have other participatory methods which are offered to citizens, civil society, grassroots organizations as well. But in most of the occasions, the language, the working language is not accessible to everybody, which may create additional inequalities in participating in policy and decision making. Another example is digital literacy. In COVID, but also in post-COVID time, we observed, let's say, a widely use of digital methods to conduct consultations with citizens, with civil society, also to organize policy dialogues with policymakers at all levels. But here again, we witness inequalities that exist in society. Not everybody has equal access to internet. Not everybody can afford digital devices. In many occasions, certain families which are exposed to poverty and social exclusion even do not have access to electricity, making it impossible to use a computer or to connect to the webinar and raise their voices and share their the challenges they are facing. This is why I would like to strengthen again the need for adequate assessment and then providing solutions which are in line with the needs of racialized population groups and respond also to the challenges they faced in participating in policy and decision making, but also in building narratives which influence policy and legislative measures. Finally, creating a safe space online and offline where racialized groups can raise freely their voices and discuss some sensitive topics is indispensable for promoting a constructive and inclusive debate. When those conditions are not met, we observe a lower participation of racialized groups in policy and decision making. And this leads to a situation when the knowledge does not reflect the realities of those experiencing different forms of racism in many areas of life, including health. As a result, the proposed solution do not always meet the needs of those who are excluded, who are actually the most excluded from society. And this is greatly relevant when it comes to health, as this is a prerequisite for the full enjoyment of multiple fundamental rights, such as right to education, housing, and employment. Many issues related to health inequity, such as unmet health needs, quality and timely access to health care and mental health prevention, remain under-addressed due to the lack of disaggregated data, allowing to better understand the gaps between racialized groups and the rest of the population. Although general studies in health exist, often they don't make it possible to quantify the manifestation of racism in health and to propose adequate policy solutions to mitigate both health inequalities and racism in society. And this is also due or influenced by the lower participation of racialized groups and civil society organizations representing such population groups in the design of methodologies for research, surveys, etc. This leads also to the lower comprehensiveness of the proposed solutions, which also impacts the general situation and does not make it possible to achieve a substantial change on the ground when it comes to both health equity and racism. In conclusion, I will say that combating discrimination and structural racism in health requires some sustained efforts to ensure first the comprehensive and inclusive process of building narratives based on a process of mutual learning, knowledge exchange, and cooperation between policymakers, civil society organizations, and racialized groups themselves. In parallel, it is essential to provide equitable solutions to ensure the meaningful participation of different groups subjected to racism and systemic discrimination to make the entire process comprehensive and inclusive. Finally, we should all make some efforts to safeguard that this process provides essential steps for further solutions to educate people about racism and discrimination and its consequences in real life. We also should make sustained efforts to increase understanding about the added value of ensuring the meaningful participation of racialized groups and well communicated to society and policymakers. I will stop here. Now I would like to thank you for your attention and look forward to address your questions during the Q&A session. Thank you very much.
Thank you so much, Radost. I mean, yeah, I couldn't agree more. It is crucial that when we want to address and when we are talking about this topic, we need to, as you say, meaningfully involve the people that are being racialized. And, you know, we must provide them with the opportunities and with the empowerment that these people would need to be engaged in a sustainable way. So as I mentioned, we would wanted to have heard from Michaela Moa. So Michaela works at DG Just, the European Commission. She's leading the EU Anti-Racism Action Plan 2020-2025. So more or less they are halfway. And we will really keep close contact with Michaela because we really want to know where is the Commission at this point with rolling out this action plan. We know that the Commission is encouraging the member states to develop their national action plans. We would have wanted to hear from her how that is going, how language plays a role. And we are also very much interested in the policy mainstreaming work that the Commission is doing. So how is the Commission with its task force on equality rolling out the anti-racism action plan within the institutions? So that is something that we will be following closely with her, and we will re-invite her for a next webinar, most definitely. And also to understand how we as a network, DisQo, can support, can incentivize, can help the Commission and the European Union in rolling out this strategy. So now we move over to Jacqueline Bouwman-Bussato. As I mentioned, she worked at EPHA, the European Association for the Study of Obesity, where she's the head of policy. So please, Jacqueline, the floor is yours.
Thank you so much, Raymond, and thank you so much to our panelists so far. This has been such an illuminating and actually encouraging discussion in how you've set out actually what are quite complex challenges. But what I'm seeing is actually a consensus on what are those challenges. And so that is already something that we can pick up on. So before I launch into picking up on some of the questions from the floor, as well as, quite frankly, I have questions too. I'm sure some people were wondering, why are the obesity scientists on this call? Actually, it's because about intersectionality again. So people of color are disproportionately represented within the subpopulation of people living with obesity globally. And part of that, as Ray mentioned at the beginning, is it's a chicken and egg situation in terms of, is it partly due to discrimination access to healthcare that stops us from going to seek treatment? Is it that we're not getting the treatment? You know, all of these sorts of things. So a lot of the discussion already resonates with the obesity, both people living with obesity population across Europe, as well as most definitely the health professionals dealing, and clearly on a personal level as well. So moving in to our discussion, there were lots of questions coming in, both on discrimination from different diverse groups, as well as specifically related to what is the Commission doing on. But I'm actually going to start off, starting from the end. So Radost, I'm going to start with you and then work my way back, because I think that a number of things that you talked about were not the usual. And I have to say, having been in Brussels, the whole environment since 1995, this is the very first time that I have seen this cross-sectionality coming from the voice of the people representing racialized populations actually coming into the health domain. So this is absolutely wonderful. But we have some questions for you. So also, I think learning from the experience of NR, because, you know, NR's been around for over 25 years, and you have championed a number of causes around racialized communities. So I think the first thing is, you know, what would you say that you've learned from other championing that you can now bring in to making sure that race discrimination in access to health, that is actually taken into account, both from the multi-sectoral and multi-stakeholder perspective, from civil society, as well as, quite frankly, institutions at all levels. Over to you.
Thank you very much, Jacqueline. So what we learned so far, it's the need for building synergies between different policies. It should be highlighted that many efforts have been done already by European institutions, but also at national level to address racism. We have a very strong policy and legislative frameworks. We have the Anti-Racism Action Plan, but today, it is necessary to integrate this intersectional approach when we are designing policy solutions to achieve a real impact on the different manifestations of racism. As I mentioned, we should need to take into account multiple factors, and not only the forms of racism. Sorry, there are some windows which are open. I will close them.
Okay.
So for us, what we learned so far is the need to strengthen the cooperation between different stakeholders, including civil society and policing decision makers, but also to ensure the active participation of racialized groups which still face barriers in in participating in policy decision making. So this is something that we would like to take further in discussions with other civil society organizations and policymakers at European level, and to identify potential solutions to fill this gap.
Excellent. And I think actually one of the questions in the chat builds on that as well. So from one Raymond Mora, I hope I'm pronouncing that correctly. He asks, and this is mostly, I think, to Irène as well, bringing you in. Are there any existing frameworks for health policy making in the EU where these stakeholders, so civil society, activists, race, gender, diverse professionals, in powers of positions, are truly included? And what power is given to these voices for knowledge creation and can form a strong source of evidence for policy making? And Rosalina, I'm about to bring you in afterwards on all of this and the data question. But Irène, what is there, and does the Commission have, from your perspective, because obviously you can't answer for DG Just, but from your perspective, what more can be done? Over to you. You're on mute.
Yes, sorry. Thank you. For instance, for Roma people, there are the national Roma contact points, and in each member state, and this is not only representatives of officials of the governments, but they can be also organizations that operate in the state, and we can have feedback by them. Something else which is not exactly representation, but it's still having a kind of echo for what is happening in member states, is through the equality bodies. And this is more for Michaela, but as she is not here, DG Justice has developed and proposed, Commission proposed on work made by DG Justice, but we were also involved. It's a proposal for setting minimum standards for equality bodies. And this has been adopted only on 7 December 2022 and has to be now negotiated with the other institutions, but the thing is how to give more power to equality bodies, because we know that in some countries this functions very well, in some other countries they are very weak, resources are insufficient, levels of discrimination are very high, etc. And we have been involved in the study that tried to see the problems before making the proposal, and health it will be covered through this possibility to have recourse to an equality body and have data from the equality body, information at least. Other possibilities, the health policy platform. We have the health policy platform and we are open to have members that correspond to these minority groups, and we have some of them on the platform. Of course, we are a health policy platform and our interest is to see what we can do for health. But I will join also what Rostina said before, that all these areas, health, education, housing, employment, are so interrelated, and we are sure that if we achieve changes, positive changes in one field, immediately we can see also a lot of positive impact in health. Of course, this does not mean that we don't have to do also our part of work.
Okay, excellent. I just want to say that I do see a hand up, but so I'm coming over to you, Johanna, be ready. But before I do that, I actually wanted to bring in Rosalina for this, because there was a lot of talk during the interventions, and something that really struck me, which has come up in the chat as well, is about, it's kind of a chicken and egg situation, Rosalina, that you're collecting data, but are you asking the right questions? And how do you, what would you suggest in terms of rectifying that, or at least taking away the bias of interpretation? Because this is something that's clear. You only get out of data what you put into it. So what would be your thoughts on this before I bring in Johanna? I'm guessing she has another topic. Go on.
Yeah, I will try to reply to the few questions that I saw also in the chat, and to what you mentioned just now. But before I come to how to interpret what you impute more or less in the questionnaire, and if you ask the right question, I would simply just try to bring in a few points that I think it's important. I will start with the intersectionality one, because there is a lot of talk about intersectionality. However, we have to differentiate between two approaches. Intersectionality as a definition in the law. So there is, in EU law, there is no protection with regard to intersectional discrimination. There is protection with regard to multiple discrimination, but not to intersectional discrimination. And as we talk about definitions, we have to clearly we have to make clear this EU legislation is not defining intersectional discrimination, but defining multiple discrimination. So the talk about importance of intersectionality, it is there, and it is important to underline that there is a awareness and is mirrored in the current equality strategies of the Commission. However, the legislation is lagging behind, and there is a clear definition that multiple discrimination is based on grounds that are separate, they operate separately, and intersectional discrimination is exactly in the intertwined kind of relation of different grounds that cannot be separated, and people have very particular experiences, like disabled Roma woman or black disabled woman can have different experiences, and this cannot be separated, but the protection is not yet there in the legislation. However, there is another approach, intersectionality as an analytical tool, for which you need the information on all the different possible intersecting characteristics to visualize and to showcase the particular experiences. So you have to collect all the data for all the different characteristics in different data sources. We are not talking about one data source. You might have surveys, administrative data, complaints data, health statistics, police data, judicial data. All that have to have similar approach, have to comprehensively cover all the relevant characteristics in order to make analysis on intersections. So there are two ways to discuss that. Then the question on what the Commission is doing or what the EU is doing with regard to collecting more and disaggregating more data. And of course, there just to mention that the Racial Equality Directive, which kind of protects based in all the different areas of life based on racial or ethnic origin, is there. However, this directive and none other directive is requesting member states to collect data, and this has been changed as with what the Irène just mentioned, with the new with the two proposals for equality bodies directive to strengthen the equality bodies, where it is explicitly mentioned that equality bodies have to collect data not only on their own work, but they have to regularly report on the state of equality comprehensively, like every 4 to 5 years, and using and having access to data collected by others. So, and there is now an important change, that there is a request if these directives are going to be then quickly adopted, that equality bodies have to make use also of data collected by others and showcase inequality also with regard to health. What the Commission is continuing to do, and just to mention for all those that are not informed about that, the Commission set up a subgroup on equality data back then in 2018, and this subgroup is facilitated by FRA. But the members of that subgroup are representatives of statistical offices, but also equality bodies or ministries sent by countries. And the subgroup already produced outputs that are helping countries, but also EU institutions, to improve the collection and use of equality data based on different grounds. First, we produced one set of guiding principles, non-binding guiding principles, how to use and collect equality data generally. Then, most importantly, we published in 2021 a guidance note how to collect and use data based on racial or ethnic origin, with facing all the challenges, talking about definition, aligning definitions. And then we also have online compendium of good practices, which is hosted on our webpage, where you can choose and see how in different countries data collection based on particular grounds have been implemented. And we've also put for use to the countries mapping tool, how to map what data has been collected in which area, on which ground, a kind of Excel sheet that countries could use for their needs. And the subgroup not only and now the subgroup is working on a guidance note on how to collect and use data for LGBTIQ equality. So this guidance note is more or less ready. Yesterday, the subgroup had a common meeting with representatives of with CSOs representing these populations, discussing and expecting their comments on that particular guidance note. And this is going to be published very soon. I think in few weeks, like in 2 months maybe, the guidance note is going to be published, and this can be used by actors collecting data, by advocacy groups, and also by the institutions. And of course, in addition, what FRA is doing, FRA continues to collect data, and FRA is preparing the third wave of the LGBTIQ survey on the one hand, but is just going to start the analysis for the second edition of Being Black in the EU, where we are also going to look at health and among other areas of life. And that second edition of that report is planned for the end of for November this year. And of course, just to mention, and I close here, FRA is involved together with the Commission in working group of Eurostat, trying to push for more data collection based on protected grounds in different surveys like the EU Silk or Labour Force survey, and of course asking also to include equality characteristics in health statistics. So we will continue to move and to provide also technical assistance to countries, to member states, and other institutions.
That is, I know we're about to run out of time, and
yeah,
I didn't get to
I
your
would say
hand.
take the online question as the last one that you promised.
Yes. So the person who had their hand up, I think, was Johanna Schiemer. Did you manage to stay the course?
Thank you very much. Just very quickly to say that we are pleased to be in this group, and just to, from our work is based on mothers and children. And what I hear about intersectionality is something that we can affirm that exists, and if it implies you put the status of a mother, that has a lot of connotations, which I just want to share with you for the ones who live in Brussels. Next Tuesday, the European Parliament, 2 MEPs, Irish MEPs, are opening an exhibition on the mandatory inquest of maternal deaths. That is a new law in Ireland, passed because of the grassroots movement and members of us in Ireland. They were fearing that maternal deaths were very much of maternal deaths of color, mothers of color. And in fact, that's proven to be the case. And this is the first step on inquiring and mandatory inquiring. So I think there is hope, as somebody said, there is hope, and but we need to join forces in order to end up all this intersectional discrimination that everybody suffers in the EU related with health. So thank you so much. I'm happy to be taking part of this network.
Wonderful. And I think that brings us back, in fact, to at the bottom of everything is going to be on what flows from the definitions. So I think if I can close this segment in terms of Q&A, thank you so much to such a enthusiastic and robust set of questions and responses from our panelists. And I hand back to Raymond to close this entire session.
Thank you very much, Jacqueline, and thanks everyone for engaging in the Q&A session. I will not summarize, but I think what was really inspiring for me, we have heard the importance of language and definitions from different perspectives, from research, from evidence gathering, from the importance to involve people. But what we also learned, and that is when we engage with the DisQo network, and it's a dimension that we should not lose sight of, is that within all of these institutions, there are also people working, and there are people that are using this language, and there are people with very different understanding of the issue as well. And I think it's very much a journey that we as DisQo are already that we have decided to go on, and that we are continuing. And that's also very much how I see this endeavor, with bringing together the different actors, but also bringing together people. So the next steps for DisQo, Irène already mentioned it. It's a joint statement that we will be producing with the network and presenting in April. I just dropped some dates in the chat. Also, the 2 next webinars, the dates, I put them into the chat. So if you want to know more about DisQo or join the other currently 39 organizations who are already engaged, please do reach out. And then finally, a big thanks to DG SANTE and specifically Abigail and Clementine, who have been very patient and super supportive in the back to make this possible. So thank you for joining us today. Hope to see you next time, and bye.
Thank you.
Bye-bye.
Thank you for this fruitful discussion. Goodbye.
Yes, very interesting. Thank you very much, Raymond, Jacqueline, Radost.
Thanks,
Thank
Irène.
you. Fantastic.
Raymond, you told that the